Hello, I'm Dr. Sara Harby, lecturer of psychiatry at Alexandria University, and I'll talk today about devices in psychiatry. Devices in psychiatry is a line of therapy which is used in the management of mental disorders other than pharmacotherapy and psychotherapy. It contains many techniques and many devices, but today I'll focus on electroconvulsive therapy, transcranial magnetic stimulation, and deep brain stimulation, because these techniques or devices are the most commonly used in the field of psychiatry. I'll start talking by electroconvulsive therapy or ECT. These days, or recently, the name is changed to be brain synchronizing therapy or BST. It's important for you to know how it works. Electroconvulsive therapy or ECT is a procedure done under general anesthesia, in which small electrical current passed through the brain, intentionally triggering a brief seizures. These brief seizures actually affect the level of neurotransmitters, neurohormones, and neurotropic factors. And also, it changes the level of activity of different areas in the brain, which is implicated or are implicated in many mental disorders. So, ECT seems to cause changes in the brain chemistry that can quickly reverse symptoms of certain mental health conditions. BST or ECT has many indications for use. According to the American Psychiatric Association guidelines, ECT could be used in many mental disorders, such as major depressive episodes, either elicited in unipolar depression or bipolar depression. Also, it can be used in mania, schizophrenia, delirium, and neuroleptic malignant syndromes. ECT is used in these mental disorders, especially in the presence of these conditions, such as acute suicidality, psychotic features, deterioration of the physical status, such as poor oral intake, which is common to occur in depressive episodes, history of poor response to medications, history of good response to ECT, also patient preference in case of extreme agitation, and also in catatonia. It's important for you to know that there are no absolute contraindications for ECT, but there are relative contraindications, such as unstable or severe cardiovascular conditions, aneurysm or vascular malformations where there is a risk of a rupture in case of increased blood pressure during the procedure, increased intracranial pressure, such as the presence of brain tumor or space-occupying lesion, recent cerebral infarction, pulmonary conditions such as pneumonia, and other conditions like pheochromocytoma, retinal detachment, and acute narrow-angle glaucoma. For the risks and side effects of ECT, there are many side effects, such as confusion. Confusion, which means that the patient doesn't know why he is here and why he is here or where he is, and this confusion can stay for hours. It usually stays for hours, and it may be prolonged, especially among elderly. For the memory loss, most common to be in the form of retrograde amnesia, when the patient cannot remember the events which occurs before the treatment, and it takes about a couple of months to be recovered. Other side effects include physical side effects such as nausea, headache, jaw pain, or muscle ache, and these side effects could be managed symptomatically by using symptomatic therapy. For recovery of these symptoms, this recovery could be facilitated by increasing the time between treatments, decreasing the stimulus intensity, and changing from the bilateral to unilateral electrode placement. And I will talk in detail about electrode placement. For electrode placement, there are two conditions for electrode placement. It could be bilateral or unilateral. Bilateral, there are two types. It may be bitemporal or bifrontal. For the bitemporal, the electrode is put about 1 inch above the midpoint on an imaginary line, passes from the outer canthus or the lateral end of the canthus, outer part of the canthus of the eye, and the tragus of the ear. This is for the bitemporal position. For the unilateral position, the electrode is put mainly on the non-dominant hemisphere in the same area, which is about 1 inch above the midpoint on an imaginary line passing from the outer canthus to the tragus of the ear, and the other electrode is put also on the non-dominant hemisphere about 1 inch lateral to the midpoint, lies on the intersection of the two imaginary lines. The first line passes from the mesial to ilion, and the other line passes between the two tragi of the ear. I'll talk now about the procedure. An anesthetic will be given to the patient before giving the ECT session. Also, the patient will receive a muscle relaxant to help to minimize the seizure and so prevent the injury or prevent the risk of bone fracture. A blood pressure cuff is placed around one ankle to stop the muscle relaxant medication from entering into the foot and affecting the muscle there, so we can check the occurrence of seizure in this part in which there is no muscle relaxants. Also, all vital signs must be monitored. Check the brain, heart, blood pressure, and oxygen use could occur. Then the doctor presses a button on the ECT machine, and this causes a small amount of electric current to pass through the electrodes to the brain, producing a seizure that usually lasts less than 60 seconds. For the frequency and number of the treatments, it's usual practice to do 2 or 3 ECT treatments per week, administered on non-consecutive days. And the number and type of the treatments the patient needs depends on the severity of symptoms, the severity of the condition, and how rapidly they improve. Sometimes it could be used daily in case of severe agitation or in case of suicidality. The patient can generally return to normal activity a few hours after the procedure. However, some people may be advised not to return to work or make important decisions until 1 or 2 weeks after the last ECT to give time for recovery of the side effects such as confusion and maybe memory loss. And now, this is a link of the video which show you more about ECT. I hope you can join. This is a question which I put to be sure that you understood the part I explained. Indication for the use of ECT include major depressive episode, mania, schizophrenia, or all of the above. Of course, it's all of the above. The second technique I will talk about is transcranial magnetic stimulation. Transcranial magnetic stimulation is a non-invasive procedure that uses magnetic field to stimulate nerve cells in the brain. And transmagnetic stimulation delivers repetitive magnetic pulses, so it's called a repetitive transmagnetic stimulation. Also, it's typically used when other depression treatments haven't been effective. Actually, devices in psychiatry in general is used in or are used in treatment-resistant conditions. And again, you need to know how it works. During a repetitive transmagnetic stimulation session, an electromagnetic coil is placed against your scalp near your forehead, and so there is an electric current which passes in this coil. This electric current is transferred to a magnetic field. This magnetic field can pass through the soft tissue, through hair, soft tissue, and also through cerebrospinal fluid. Then this magnetic field will be transferred again to an electric current which can affect neurons, can cause depolarization of the neurons in different areas implicated in many mental disorders, especially depression. For the risks of transmagnetic stimulation, repetitive transmagnetic stimulation is considered safe and well tolerated. However, it can cause some short-lived side effects such as headache, scalp discomfort, and facial muscle twitches, which could be managed actually symptomatically by using symptomatic therapy. And again, this is a link of a video. I hope you to join and to know more about transmagnetic stimulation and how this procedure occurs. Again, this is a question about repetitive transmagnetic stimulation. Repetitive transmagnetic stimulation is considered unsafe as it is an invasive procedure. True or false? Of course, false, because repetitive pulse magnetic stimulation is safe procedure and it is non-invasive procedure. And finally, I will talk about deep brain stimulation, DBS. Deep brain stimulation involves implanting electrodes within certain areas of the brain through small holes created in the skull. And these electrodes produce electrical impulses which can regulate the abnormal impulses. And electrical impulses can affect certain cells and chemicals in the brain. The amount of stimulation in deep brain stimulation is controlled by a pacemaker which is connected to these electrodes via a wire passing under the skin, and this pacemaker device is put in the upper chest. A few weeks after the surgery, the device will be turned on and the process of finding the best settings for the patient begins. Some settings may cause some side effects, but these often improve with further adjustments of the device. There are many uses for deep brain stimulation. It could be used in the management of Parkinson's disease, essential tremors, dystonia, epilepsy, and in obsessive-compulsive disorder. For the risks related to deep brain stimulation, because this technique is invasive, so there are many complications of surgery which include misplacement of leads, bleeding in the brain, stroke, infection, breathing problems, nausea, heart problems, and seizures. And this is a link of the video which show you more about deep brain stimulation, and I hope you join and enjoy watching it. The last question in this lecture: devices in psychiatry are mainly used as first line of therapy in all mental disorders. True or false? Of course false, because devices in psychiatry are not the first line and they are not used in all mental disorders. Actually, they are used in treatment-resistant conditions. And thank you.